All right, ladies and gentlemen, we're going to begin joint committee meeting on education. Can I have your attention, please? We don't have a quorum at the moment, so we're going to move on to item 4 on the agenda, mental health study for students in higher education institutions. We'll begin with Dr. T. Ann Hawkins, Director of the WVU Caruth Center for a Provider Perspective. Dr. Hawkins.
That's a great way to start, right? So, how do we advance the? Oh, there we go. All right. So I'm really thrilled to be here. I'm the director of the counseling center. I'm a psychologist, and I was born and raised in West Virginia. I'm a storyteller, and psychologists are storytellers. Appalachians are storytellers, and I really think that we have to tell the story of collegiate mental health. And I don't know that I'm the best person to tell it, but I can tell you I've been living it. I've been breathing it, 24/7 for a while. So I'm going to tell you a story. I was born and raised in West Virginia. I spent a year at Ohio State. Couldn't stand it, which is, I think, is a bit of a discussion with President Gee and I. Came back here, and I've been working at the counseling center for many years. I have come from a family of 6. 5 of us graduated from WVU. My son graduated from WVU with an industrial engineering degree. And the reason that story is important is because that's the lens that I see everything through. Like you, the lens that I see collegiate mental health through, the lens that I see the struggles that our students are experiencing on a daily basis, that we're all experiencing in West Virginia, is that parent lens, that daughter lens, that Appalachian lens. So what we know is that our students are absolutely really struggling. We know that they're disconnected. These, what you're seeing on the screen right now, these come from the headlines of newspapers. The college counseling centers around the state and around the country are one of the most popular places on the campus, and they have been for the last 10 years. We increasingly are seeing more and more students. The difficulties in collegiate mental health, it's not just a pandemic problem. Okay, so this started long before the pandemic. We look at data, and what you're seeing in front of you are trend lines. And when we look at the data, and I'm actually going to go through the data really quickly because Jeremiah and I conferred, and he's got some really great data to share. But what you're looking at, these are trend lines over the past 10 years, from 2010 to 2020. And what we see in students who are accessing services, these are students who go to college counseling centers. What we're seeing is a dramatic increase in depression. We're seeing students who are more anxious. We're seeing students who have more distress. Interesting, we're seeing a decline in substance use. And I think that has to do with who presents at college counseling centers. Other data that I think is important for you to see, at college counseling centers right now, we see more and more students who present to us already having had multiple episodes of care. They've already been in counseling in middle school. They've been in counseling in their elementary schools. They've been on medication. Some of them have been hospitalized. The other trend line, and I won't go through all of this, but the other trend lines that are really important to pay attention to, we're seeing more non-suicidal self-injury. And what I mean by that is we have more and more students, who are injuring themselves by cutting themselves or burning themselves or hitting their heads. That has been something that we, as a culture, we're seeing more and more in the middle schools, in the high schools, and on college campuses. We're also seeing more and more serious suicidal ideation and suicide attempts. And Jeremiah will talk more about that. The increase in traumatic experience, I think, is also pretty profound. More and more of our students are coming in having experienced unwanted sexual assaults. They've experienced harassment. Our minoritized students, our marginalized students come in with an experience of racism that is really profound, that affects their mental health. So we see more and more students who come to us, they're with less resiliency, they're vulnerable, and they have less coping skills. So I want to talk to you about the counseling center. So I'm the director of the counseling center. I'm a psychologist and have been doing this for a while. Pre-pandemic, we were seeing almost 120% increase in crisis intervention appointments. So we were already ratcheting up. We had an increase in drop-in appointments. You know, in some ways, it felt like we were given a sippy cup and we really needed a fire hose. You know, that's what it has begun to feel like. During this pandemic, we've pivoted to virtual sessions, although frankly, the fall semester, 92% of our sessions were held in person. And you might ask, well, why would they want that? Well, I think the reason they want that is because they want to connect. They want to be in the same room with someone who looks at them, who sees them, who hears them. So, you know, we've had increases in suicidality, no question about it, and I'll talk more about that. Our crisis interventions since the pandemic started up by 36%. The volume of students presenting has increased our referrals off campus. We're up to, we have a 40% increase. This year, we will have served about 10.7% of the student population, which is pretty tremendous. 30% of our clients, our students who come in, report self-injury, 31% report suicidal thoughts, and 13% report a previous suicide attempt. Think about that, 13%. So at the counseling center, we try to make sure that we're available to do personal counseling, but we want to be available to see students who walk in, students who are in crisis. So we've dedicated, we have 130 crisis hours that are available. We have, we average almost 500 counseling sessions in a week. And in the context of all of that, managing emergencies, we're also on the campus doing outreaches. And I'm going to digress for a minute, but we did 265 outreaches for 12,000 students. And why that's important is because you're going to hear a little bit about how we have to work on mental health upstream. 50-minute hours, sitting with a student for 50 minutes is not going to fix this. Every time I'm in Stewart Hall, President Gee asks me, how do we fix this, Tian? How do we fix this? You know, we don't fix this with 50-minute hours. We have to be in the community with our students. We have to help them learn coping skills. We have to help them learn what I like to call adulting skills. And I think some of you who are parents know exactly what I'm talking about. But we have to be out in the community. And that's part of what we do at the counseling center. So we're out there whitewater rafting with students, or we're out there doing crafts with students. Why this is important is because the crushing mental health crises are making it very difficult for counselors to do any of that work. And that's the most important work. So more data, you know, so we have an after-hours service, and that's really important because those of you who have you know, adolescent teenagers or have raised children or have nieces or nephews, you know that nothing happens during the day. It happens at night, right? It happens on the weekends. So in 2018, you know, we had 159 interventions and 2 in-person interventions. This year, 242 interventions, 7 in-person interventions. That's a 42% increase. So the counseling center staff are weary. There's no question about it, because we're operating as if we are a psychiatric emergency room. So this slide is really compelling. And I asked my friend, the chief, to come in case there were any questions about this, but this data comes from Campus Police. These come straight from the police reports. So in 2019 and 20, if you look at the last column, there were 40 welfare checks. And what's a welfare check? A welfare check would be something like a parent calls us and says, Dr. Hawkins, my son just sent a Snapchat or sent a text to his sister saying that he might kill himself. And so in that case, we're immediately going to dispatch Campus Police. Or a parent might call us and say, I haven't been able to reach my son or daughter in the last 3 days, and he has a history of suicidality. So those are the kind of welfare checks that our campus police officers, in conjunction with the counseling center staff, do. We went from 40 to 81. That is significant. If you look at the suicide attempts, we went from 5 to 10. And, you know, it's not a secret that we've had suicides on our campus, and you know, there's a national sort of context for an increase in suicidality on university campuses right now. So this data is really important because It speaks to some of the recommendations. So all of this, I think, in many ways creates a perfect storm. You know, we have a powder keg, you know, and I'm not one of those people who says, you know, that the sky is falling. You know, I tend to be pretty laid back, but I'm very concerned. And I think this is not unique to WVU. It's not unique to the state of West Virginia. We are seeing this across the nation. We are seeing, you know, University of Georgia, all the Ivy League schools, University of Wyoming, multiple student suicides. And it's certainly concerning. So they asked me to talk about what is it like to work at the counseling center. And so this is sort of a day in the life of a counseling center. So 1:10 a.m., we may get a call our after-hours service. We may have to do a welfare check. At 7:30, and we may be up doing that for a couple hours and working with Sherry's staff or working with the behavioral intervention team. We 7:30 a.m., I may be interfacing with candidates trying to schmooze people to get a job, because frankly, there is a significant mental health clinician crisis right now. We can't fill jobs in the state of West Virginia. We're having trouble filling them nationally. So we're shamelessly trying to get people to come here. So we're going to have calls from students. We're going to check on students who potentially have COVID. We're going to do outreach, mental health 101 with faculty and staff. We're going to have crises walk in all day long. We could have a sexual assault that we're managing. We could have a death in someone's family. We're going to do personal counseling sessions until about 7 o'clock. At 8:05 p.m., we may have another situation related to student conduct and suicidality. And then from 8:30 to 10, we may have staff who are working with our student life, clinicians who are working with our student life staff. This all happens on a regular day when we're also doing 125 counseling appointments, doing 8 to 12 urgent crisis visits, you know, and we're managing calls from people like you, from parents, from the community, and from our students. So these are very busy days. Now, we're a bigger center than most in the state. So, but if you take this and you sort of look at it, you know, decrease the volume, this is what's happening at Davis and Elkins. This is what's happening in all of our college counseling centers right now at a different volume. This is certainly what's happening at Marshall. Okay, so one of the things that I know is that when I am asked to do something, I always think, you know, I don't know that I'm the expert at student mental health across the state. I think that I know a lot about how do you run a large center, but it seemed really important for me to collaborate with the folks, the directors of college counseling centers across the state. So one of the things that I did was I collaborated with Marshall, which is unusual partnership, right? Because I'm not allowed to say the word green in this room. But so Candace Lane and I, who's the director at Marshall, developed a survey. We sent it out to all the directors in the state of West Virginia, and we planned a focus group. And we did that intentionally. I had a sense of what they might say, but I wanted to make sure that I wasn't misrepresenting them. So we asked them a few questions, had about 18 people respond to the survey, which is pretty good for something that happened pretty quickly. So the top 5 services and support that they think students need access to or more of: psychiatric services. Overwhelmingly, that's where they started. And on our college, in rural areas, as you may know, access to psychiatric care is very challenging. Mental health and wellness screening. They want to be able to do some sort of screening when students come in so that they can better meet their needs. They don't have time to do that now because of the crushing volume of work. Longer-term counseling services beyond the first semester. Or a year. We have students, especially in rural areas, that have very difficult times accessing longer-term therapy. And if we saw every student who needed to be seen as long as they'd like to be seen at the counseling center, we would be filled up within 5 weeks. Okay. Access to more frequent appointments. Students like to be seen more frequently than once a month or twice a month. And that has become the norm at many college counseling centers. Students are telling us, and counselors are telling us that students need more peer mentoring, not peer counseling, but peer mentoring, wellness coaching. And my colleagues also, the 5th item that they said is really critical is 24/7 for an after-hours service. Now, I put that in bold because, frankly, that's what I would lead with. I'm a practical person, and right now we have a situation where we have college counseling centers that do not have after-hours services. There's not a place for a student to call when they're having a crisis. So that to me feels like a basic need that we've got to meet. Top 3 services that faculty and staff need to assist students, and I think these are sort of redundant, but more counselors. They're not able to keep up. Funding increases for clinician salaries to recruit and retain staff. I was floored when I heard the salaries of my counterparts in the more rural colleges. Their jobs are not easier than mine. And in fact, their jobs may be more difficult. Funds to provide prevention, outreach, wellness, and resiliency services. We're not going to solve this by just sitting with students and talking about their feelings. And that's my job, is to talk about feelings. We've got to do prevention. We've got to teach adulting. We've got to help them with some basic skills. So we also asked them, what happened when the pandemic hit? And so almost 70% of the directors that we surveyed reported higher volumes of scheduled counseling appointments. And that's happening nationally. Most centers were not operating virtually. They didn't do telehealth, so they immediately pivoted to telehealth. And we've been being hybrid since then. 53% of the directors reported higher volumes of walk-ins or unscheduled telehealth appointments, which is exactly what we're seeing. Adjustments to address the pandemic, because we're doing so much more. All of a sudden at WVU, we were also calling all the students who had COVID, and that was important. But we had to fit it in. So how do you fit it in? You expand your hours. There's longer. You stretch out the sessions so you don't see someone as frequently, which is directly correlated to decreased clinical outcomes. Students get better faster if we can see them more frequently, and we decreased our prevention and outreach. So, and I'm going to give you all of this, so don't feel like you have to kind of pay close attention to the data. So what do we need? When I review the survey from the directors, and when I think about the focus group we did and the discussions that we've had with multiple students. So I'm a brass tacks kind of person. And so they're very specific things like a crisis intervention service that's available to all of our students. Phone lines, crisis mobilization teams. We're working right now to try to partner with Valley to make sure that our community has the return of a crisis mobilization team. Because if someone's having a psychiatric emergency, it is better for them to talk with a counselor, no offense, chief, than a cop. We need additional counselors. We need salary reviews, more psychiatric services. We have to collaborate better with campus and community partners. When we try to refer someone for psychiatric services, especially in a rural community, there may be a 3-month waiting list. When someone is having an acute psychiatric episode, waiting 3 months is really not doable. We have to flip the clinical model, and I've been talking about that without using the words, but when I was hired to blow the center up. I was hired to bring the center to a more student-centered place. And that means we have to get the counselors out amongst the students. And the only way I know to do that is going to be to increase staffing. We talked about integrating coping skill and resiliency building, adulting content. We've got to do that. We have to be better in terms of doing telehealth, especially with marginalized students. We also have to train our frontline faculty. They're the folks who are seeing our students. So on all of our college campuses, we have got to train faculty and staff and students better. So some of these I've mentioned already. So recommendations, we got, in terms of the long term, we've got to figure out how to increase the number of clinicians in West Virginia. And this is a national problem. I think we've got to grow them. Frankly, I think we've got to partner with our master's programs and figure out how do we increase the number of graduates, just like we've done with nursing and primary care physicians. We've got to support initiatives to place clinicians in elementary, middle, and high schools. That's where this starts. By the time they get to the collegiate level, they're pretty far along sometimes in destructive behavior. We've got to increase campus and community collaborations. We have to think bigger. We have to share resources and high-tech solutions more effectively and efficiently. So for example, WVU has an after-hours service. It would make sense to me to have one contract for one service. If we're buying an app, it makes more sense to look at an app across the board for all of our state colleges, rather than just WVU. And that's my goal, frankly, would be to take some of the services that we've been so fortunate to provide at WVU and get them to more rural campuses. So I think we also absolutely have to bring together mental health experts to develop a comprehensive plan. And I always hesitate to say that because in my family, when my parents would say, we're going to study it, I knew what that meant. I knew that meant it wasn't going to happen. I think we have to study it, but I think while we do that, we've got to get guardrails up. And what I mean by that is we have to think through the staffing immediately, and we've got to think through the safety, and we've got to develop a plan for emergency response. So all of the suggestions that I've made fit into all of these categories. The focus is decreasing stigma, enhancing and expanding digital and mental health services. We've got to work upstream. We've got to increase connection and sense of belonging. You know, we've drifted off course, you know, and we don't, and that was beginning before the pandemic. We've got to increase connection, and we've got to create a culture that values well-being. So that's me taking more time than I was supposed to. So Jeremiah, you're up. I know you'll have a chance to ask questions in a few minutes.
Thank you. Thank you, Dr. Hawkins, and thank you all for being here today. I'm Jeremiah Hawkins. I'm a psychiatrist through WVU Medicine, and I'm the medical director of Healthy Minds University. Going through the med school route, I'm a little bit more well-traveled. I'm from the southwestern part of Virginia, and when I came here, I learned real quick there was quite taboo to saying that you're from Southwest Virginia because nobody knows which side of Beckley that is. Nobody knows if that means Williamson or Wise, Virginia. So I am from across the border, but not too far, also from a small community, a small rural town, Wise, Virginia, which I think many of our students are from a similar area. I've been here since 2015. I got my passion for student mental health as a resident physician. I was at East Tennessee State for it, working with a young Appalachian population, fell in love with the job. I hope to be informative today and will be available for questions afterward. I believe kind of an outline, tell them what you're going to tell them. Basically, I just want to try to back up Dr. Hawkins with some of the national data, some of the data from medical entities such as the CDC, as well as some of our own experience from launching a clinic here on the campus of WVU we've entitled Healthy Minds University. What the CDC data says is essentially consistent with what Dr. Hawkins reported and what we're seeing here. Very large increases in high school students based off the CDC's Youth Risk Behavior Survey, saying that they experience persistent feelings of sadness and hopelessness, seriously considered attempting suicide, got to the point of making a suicide plan, attempting suicide, and were injured in a suicide attempt. 2.5% in 2019. That's a big number. Maybe 2019 was a bad year. Is that maybe a blip on the radar? Not really. The CDC's data shows kind of a trend up for all those measures. I'm also more than happy to make the slideshow available, so please don't fall into the numbers in this either. Just want to, basically relay the message, let you know what we're seeing. As well as if anybody's ever played around with the CDC website, there is a interesting way that you can sort of put in your data, have it spit out a chart, causes of death for various types of age groups. To me, this is a really uncomfortable pick because it is very uncomfortable to think about suicide, especially in the context of young adults, young people. This particular chart does have play with the age range a little bit. It goes by 5-year intervals until you get to the age of 25. But what it does point out is there is this peak in adolescence, teenage years, young adulthood, that this is one of the more common reasons for the loss of life in young people. But that also means there's opportunity. If we can find a way to reach them to make that better, there's opportunity to make some changes. Also, some other things that go along with it, right? Sometimes mental health can be associated with impulsivity, which can lead to unintentional injury, homicide. 100%, absolutely not, but maybe a percentage of those cases. CDC's not collected or updated their entirety of data over the past couple of years, but there is reason to believe that it continues to go up. We have our data, which Dr. Hawkins showed with you. A CDC weekly report in June 2020 showed a greatly higher rate of those that seriously considered suicide in the 18 to 24 age group compared to all adults. And just numbers that continue to go up as a result of the COVID-19 pandemic. 44% feeling sadness, hopelessness during the past year. 55% emotional abuse by a parent or other adult in the home. It was a real stressful time for parents as well. I can say that as a parent. Many of the people I know that we see at our kids' baseball games and swimming events, we know several that lost their jobs. COVID-19 was hard on a lot of people. The kids were feeling a lot of this brunt as well. They were really feeling emotional abuse, they reported, a greatly increased physical abuse risk. 29% reported a parent or other adult in home lost the job. There was a USA Today op-ed recently that looked at a number of colleges. Basically, the point of the op-ed is that colleges need to report mental health statistics like they do other violent assaults and sexual assaults. Some of the numbers that jumped out to me was how common of an issue. It's not just a WVU issue. I know Dr. Hawkins mentioned how it can be an Ivy League issue. It's happening everywhere. A Washington Post article from this week. I knew I was going to give this talk, so I had to pull this one up. But this one is focused on college athletes. 2015 study found that they had a lower rate of suicide than the general population. But in the first 4 months of 2022 alone, the number appears to be substantially higher than in the past. Quotes a researcher at Penn saying that this is really more of a university and college issue rather than an athlete-specific issue. The U.S. Surgeon General recently released an advisory in 2021, noting a lot of the same factors that we talked about. I'm not going to make you sit through those as well. Basically, he said that there are a number of negative correlations, a number of special at-risk populations, youth in rural areas and low-income youth. That's a lot of the college students I see. They were there in that spot. No psychiatrists, no mental health opportunities. College, especially if they come to WU, might be one of the first chances we have to reach them. A number of other factors as well. Basically had some top line recommendations. The ones that most stood out to me: ensure every child has access to high quality, affordable, and culturally competent mental health care. Support the mental health of children and youth in educational, community, and child care settings, and increase timely data collection and research to identify and respond to young mental health needs more rapidly. Basically, let's get a handle on this. The CDC recommendations, circling back to them, placed a big emphasis on feeling connected to family, feeling connected to school. They define a sense of connectedness as a sense of being cared for, supported, and belonging. If we're doing remote school, it's how are they going to feel like they belong to the school? That's a challenge. That was a challenge. Not only is it we're talking about suicide, which again, very taboo. We want to do all we can about it, but might this just make better lives? It's certainly a tragedy when somebody with diabetes ends up in the emergency department because it's uncontrolled. Maybe they miss a few days of work. It's even worse when they die, but even if their diabetes is just uncontrolled, it's a big quality of life factor for them. If we can treat anxiety, if we can treat depression, maybe there's in the mild to moderate range, keep them in school, the data shows that they're going to be more productive. They're going to live better lives. They're going to be able to have better jobs, better careers, contribute more to society moving forward. So here at WVU, one initiative that we've taken is launching a new clinic under the umbrella of WU Medicine entitled Healthy Minds University. Healthy Minds, kind of the new motto for a lot of our outpatient clinics. Over at Chestnut Ridge Center, there's new signs up now that say Healthy Minds University or Healthy Minds Chestnut Ridge Center. So there's some branding going on here, but I represent Healthy Minds University. It is a multidisciplinary behavioral medicine and psychiatry clinic that will assist students with longitudinal medication management and/or psychotherapy needs. One of the big things Dr. Hawkins pointed out, a lot of students don't have access to psychiatry, especially if they're from the rural part of the state. We also want to have collaborative relationships with the Caruth Center for Counseling and Psychological Services, Student Health Services, Student Life, and additional clinical support to ensure that the transitions of care from the emergency department and inpatient are streamlined. Those are probably our highest at-risk students, the ones that are in the emergency department or get discharged from an inpatient setting, and there's a lot of them. It is not a replacement for the Caruth Center. We're not trying to replicate or start doing what it is they're already doing and what Dr. Hawkins already presented. We're not trying to replace the emergency response numbers, the emergency room, the inpatient care. We are truly a hole that was in the system that we are now trying to fill. We get lots of new patient referrals. It could be a discharge from the ED or the inpatient unit. The student could call in themselves and request it. It could be from the Caruth Center. We also get referrals from our campuses in Beckley and Kaiser, WVU Tech and Potomac State. And we also have a number of return patient visits, individual therapy appointments. And we're doing this with a pretty small clinic at this point. Right now we have one psychiatrist, myself. We've had another one helping one day of the week, some weeks of the semester, a nurse practitioner and a physician's assistant, 2 therapy providers, some group therapy. But the big question, what information can we give you from our experience? What have we learned from this clinic? Telemedicine is super helpful. One really cool thing that we're able to do is use WVU Medicine's MyChart system to offer telemedicine services, to offer video connections. I'm going to go over a couple situations later, which this is very key. This is very helpful to maintain care for our students. The data. So this is our fall data. This was while we're still building up. This is me, a couple case managers, and 2 therapy providers each there one day a week. What really stands out to me in this data, one, the show rate. Most weeks were better than the general community clinic. This is actually pretty good for a mental health clinic. We ride 89 to 90%. Fall break happens, Thanksgiving week happens, Christmas happens, and we drop down to about 50%. It has an impact on our data. We've noticed that. We're thinking of ways to correct that in the future. What Dr. Hawkins mentioned about students craving in-person attention, the number of our in-person visits versus telemedicine between students in the community, a huge discrepancy, 22.7% versus 59.6%. The number for the spring semester really picked up. We got our therapy providers in, we got our APP providers in. If you build it, they will come. Our telemedicine rates increased. We think that's going to bump even further over the summer. The PRT normally drops students off at our back door for in-person visits. That doesn't run during the summer. So we're expecting a higher percentage of students to utilize that over the summer months. We're really looking forward to our annualized data once we have a chance to collect it. Telling you the same thing, just kind of in chart format. APP, 0 therapy visits, not many to start out. Mainly was our psychiatrist offering that psychiatry medication management to the Caruth Center and the W students. That was really, honestly, all we offered in the beginning, although we were still building the plane and the different parts of the plane. As we started the clinic, we wanted to offer the service as soon as we possibly could. This looks a little bit more natural, a little bit more right. We have 2 full-time counseling providers now. Now, if you're a therapy or a counseling provider, you have 1 appointment an hour. If you're a MedCheck provider, you have 30-minute visits for each return. So between me and 2 APPs, we're able to see more patients than they are. Our annualized data. I also think the other thing that's clear about this, as well as our waiting list in the spring, if we had more therapy providers that offered long-term therapy, we'd be able to fill them up easily, quickly. We could have done it this past semester. Some of the encounters that we see, what really stood out to me, the top 5 diagnoses or versions of anxiety or depression. College students are anxious, college students are depressed, major depressive disorder. As well as that, and that's not all that we see, a number of diagnoses here. Some of the most heartbreaking stories that we get are the PTSD cases. Some of the most important things that we do is talk about substance use, which I think is underrepresented on this chart because a healthcare provider is a little bit hesitant to tag an 18 through 22-year-old with a substance use disorder diagnosis. Some of the barriers that we've encountered, the cost, some students can have bills that add up. Say you got connected to care going through the emergency department, you were in the hospital for a little bit, you get out, they tell you need weekly therapy, which has a copay, monthly medication management. One of the first questions I hear is, hey doc, can we eliminate the therapy? We can. If it were somebody in my family, I wouldn't want that to happen because therapy has the benefit without the side effects of medications. For me, I'm kind of a wannabe therapy provider. So that would be the first treatment I'd want somebody in my family to have, although that is a little bit more expensive and it adds up in our copays. Not only the cost of referral, but sometimes we have smart students. They say, hey, what's the cost going to be before you refer me? I want that in writing. And what's the normal line that we say? Check with your insurance company. They're not going to do it. They just don't come see us. And so, but we do have a couple students who request that. A concern about what will be disclosed to parents. Will my parents get a billing statement? And this just isn't saying parents are generally not supportive of care. I've had a number of students say, I don't want my parents to have to worry about paying this. They're struggling as well. Maybe it is other reasons, a substance use or an addiction related issue. Other barriers to care or potential waiting lists for care, going home to the summer. We're trying to use telemedicine, and that's one of our big goals this summer, to maintain that care if they're in West Virginia. That can be a challenge if they don't have a broadband connection in some capacity, in some way. A home Wi-Fi connection, a 4G, 5G cell signal. My chart's pretty compatible. It can make almost anything that they have work, but they just have to have that data speed. And retention. If we lose them as a student, we've lost them in care. So anything that we can do that helps college retain students also helps them stay connected to care. The goals of the clinic, we want to coordinate with all our partners to identify the most at-risk students, provide the best possible care, to meet the students where they are. I mean that in multiple ways, physically on campus regarding their treatment plan. To provide hope and longer term treatment to students dealing with a range of emotional and psychological issues, including substance use and addiction, and to start the process of them becoming successful in life and overcoming challenges. I've probably already gone over, but this is my last slide, I promise. What we want to do is some of the current and future implications moving forward. We can better connect them, get them connected to other W medicine treatment resources. The number of referrals I've placed to dermatology and rheumatology would surprise you. Students calling me saying, hey, I have no idea where to start. How can I get connected to this other source of treatment? Our ability to connect them to other treatments within the W medicine system, such as the intensive treatment clinic. In layman's terms, that's the day hospital or intensive outpatient, a treatment you go to on a daily basis, or a treatment-resistant depression clinic where they focus on things like ECT, TMS, transcranial magnetic stimulation, and other non-medication-based treatment. Collaboration with the Rockefeller Neuroscience Institute for larger clinical trials and research. We've had one meeting with Thrive Global about wearable technologies. Maybe somewhere down the road it's something that we can actually enroll our students in. Wouldn't that be so cool, just to get them a wearable technology that can track their vitals, look for signs and symptoms that are evidence that their anxiety is getting worse, as well as assist them with breathing exercises and meditations. Not only do I love therapy, I love non-medication based treatments of any sort. And the potential for additional long-term therapy positions. Telemedicine may provide us additional off-site provider options. We're using that in a number of cases, but we're going to have a wider, more consistent treatment reach if we can utilize telemedicine to our full capability. A couple of pictures, thank you. And I will also be back for questions at the end.
Thank you, Dr. Hopkins and Dr. Hawkins. We do have one more speaker, so we'll let her speak, and then if we have time, we'll get to questions. If anyone does have other questions, I'm sure, an hour is not a lot of time to go over this large topic, so you can submit anything to the clerk, and we'll try to get back to those, get them answered by next meeting. Before Ms. Hernandez speaks, we do have a quorum, so we have one item on the agenda we need to knock out. So Co-Chair Rucker moves that we approve the minutes from the Monday, April 25th meeting. Any additions, deletions, corrections? Chair hears none. All in favor, aye.
Aye.
Any opposed, nay? Ayes have it. Minutes adopted. We have Ms. Chloe Hernandez, Student Body President, WVU. You have the floor.
Hi, everybody. It's nice to see all of you. Like I was introduced, my name's Chloe Hernandez, and I'm the current Student Body President of WVU. I'm also a senior studying neuroscience and psychology. Running for Student Body President and now being in office, I've had the extreme privilege to talk to students from all areas of campus. When engaging with them, the number one concern in all of our conversations has been the mental health of our student body. Often, we hear mental health as a buzz term for many different situations and issues. To really refocus the meaning of this term, it's really essential to examine the events that have occurred on our campus, the resources we currently have available, and most importantly, how we can better serve our students who are the heart of the university and the future of our state. To kind of go back in time a little bit and talk about some things that have had happen on campus. In April of 2021, I remember walking back to my apartment at University Place around 12:30 p.m. I was about to begin studying for my chemistry final with some of my friends, and it was really a pretty day out, sun out, shining, seemed really normal, perfect temperatures. But as we were approaching my place, we saw a scene that quite literally shook West Virginia University and the city of Morgantown. For those of you who may not know, a young man had jumped from the parking garage across the street. You could see the horror and disbelief on almost every single person's face. And news of this tragedy spread quickly throughout our campus, followed by deep sorrow of losing one of our fellow Mountaineers. For weeks after, mental health and resources available on campus became a primary focus of discussion among students. The Student Government Association hosted a town hall to examine issues on campus and discuss how to best address these while collaborating with university administrators. Students were posting mental health resources on their social media, friends were checking in on friends, and finals were the last thing on anyone's mind. The pain and sadness that our students felt also came with questions. Why did this happen? Why did no one notice the signs? And what and where were the resources available for us? This unfortunate situation forced us to begin answering these questions. Answering these questions allowed us to notice the gaps in the current resources available, along with places for us to improve collectively. More importantly, this incident showed us how to be there for the Mountaineer family to prevent another tragedy. As the year continued, the conversations began to settle. But a few months later, in December of 2021, a note was found on campus detailing what would be another incident of self-inflicted harm on campus. As you can imagine, worry spread quickly throughout the campus, and conversations focused on mental health resources became primary focus yet again. When these events and tragedies happen, many people ask, why did they just not go to therapy? Or imply statements like, nothing's that bad. However, mental health is not a slap a Band-Aid on it and move on kind of issue. It's complicated. It's different for every individual to define mental health and how they manage it. Often people make bold assumptions about combating these crises in today's society. Statements to toughen up are made while ignoring compounding factors contributing to the increase in those experiencing mental health concerns and using the available resources. Scrolling on TikTok or Instagram, it's really easy to assume that life seems perfect for other people, and it sets an impossible standard for our youth. However, with modern stressors such as social media, the pressure placed on young people to be perfect is intense. The pressure especially is true for those in competitive academic fields who feel the pressure to maintain a 4.0 GPA and balance extracurriculars to continue to graduate level education like medical school or law school or securing a dream job. Where the real danger sets in, however, is where students don't know how to access the resources to navigate these new complexities in the intersection of social media and mental health. As Dr. Hawkins and Dr. Hopkins mentioned, there are several great resources on WVU's campus, but the accessibility to these resources can often be limited for our over 26,000 students on campus. Serving such a large student body, providing long-term care or having appointments longer than 50 minutes can often be difficult, especially when looking at the increase in numbers from the Carew Center and Healthy Minds. These resources have to adapt to the increased student demand, but preventative care doesn't stop there. Change is a continual process, and constantly re-examining the needs of our student body and the capacity of existing resources is much larger than an internal WVU solution. To better serve students across the board, at a national level, at a state level, and at a WVU level, it is vital to invest in their mental health by improving accessibility to mental health resources, be it by increasing the number of clinicians or introducing better ways to keep students mentally well. Thank you.
Thank you, Ms. Hernandez. The other two speakers would like to come up, and we'll try to entertain a few questions. We have a couple minutes. Any questions for any of the presenters? Delegate Jennings, who would you direct to? To her. To Ms. Hernandez?
Press.
Dr.
Hawkins.
Okay,
Dr.
wait.
Hawkins, okay. Chloe, you can stay up here too, please.
No, I'm sorry, Dr. Hawkins, I'm sorry.
Delegate
Okay,
Jenkins, press the,
There you go. My question is, I know that you're focusing on fixing the end result. Are you doing anything to slow down the mental issues down in the younger grades?
So we are not at the counseling center. I mean, frankly, we're so caught up in just managing what's happening at the collegiate level. We've begun discussions about how do we manage this downstream. And one of the conversations that I've been having across campus, quite honestly, is I do think we have to embed counselors, in elementary schools, in middle schools, in preschools. We have to create training experiences for graduate students to learn how to work with youth, because it's very challenging. By the time students get to us, some of these patterns are already learned. And frankly, it's not my lane. My lane is the collegiate lane. But I don't think we can fix this at the college level. We have to start earlier. We have to teach young parents how to parent. We have to throw more counselors and more wellness activities into the elementary schools. So that would be my fix. But I know Dr. Hopkins may also have ideas.
I do know that our work environment is a little more segmented. We have our own child and adolescent section within W Medicine that works with the younger individuals. I do know that they're using telemedicine more and more to try to connect with as many young peoples in various parts of the states that they can. I also know they have a very long waiting list for outpatient care and an inpatient unit that was nearly full earlier this morning when I was rounding. And so it's, so I don't know that'd be the best person to answer it, but I do know that they are working hard with the tools that they have as well.
So I can tell you anecdotally, if you have a young child who has a psychiatric issue, they may wait in an emergency room for 2 or 3 days for a bed. It may take months to get them to see a therapist. And then here's a silly idea. They're doing play therapy virtually. They're using telehealth. Now, that's a challenge for a 5-year-old to be having to be using telehealth. So we've got to get therapists, we've got to get social workers into rural areas. And how do we do that? I think we've got to grow some.
Senator Beach.
Thank you, Mr. Chairman. And this either one of you can field this question.
It's hard. He's going to take it.
I don't think I'm interested in first contact and how that is achieved here on campus. And a second question to follow that up with is in regards to, did some of this come to the forefront once you advanced telemedicine, once it became easier for the student? Did we see these numbers advance for that reason? And were these problems already existent? They just weren't coming forward and this made it easier? So
those are really good questions. So how does a student access services in a typical college counseling center? Is they will call and schedule an appointment, or in our center, we have a drop-in service. So they'll come in, we have a crisis urgent clinic. So they'll call or they'll walk in and we have people ready waiting to see them. We realized that they wanted to have more of a McDonald's sort of approach. They wanted to be able to drive through and they wanted to be able to access us quickly. So we're waiting for them, which is really critical. So this is not a pandemic problem.
Thank you.
Absolutely. This is 10 years in the making. We've been seeing this increase for the last 10 years. We have 10 years worth of college student data that tells us this began long before the pandemic. And the pandemic has made it worse, but the pandemic's made a lot of things worse. We're all more vulnerable. Our skins are more thin. And not only do we have the pandemic, but we have a recession. We have a war. So we're juggling a lot.
Thank you.
Further questions? Okay. Look at Rich.
Thank you. For either doctor, what does the legislature need to do?
That's the $1 million question, right? I think we've got to study this. So I'm not an activist, a politician, and I have to say I so appreciate having the opportunity to talk with you today. It is such a pleasure to be able to share what I think about this, honestly. I think we have to put together a multidisciplinary task force that has behavioral health care clinicians, that has students. Chloe is a great representative of our students. We have many students across the state who can give us ideas, but we've got to have clinicians, and we've got to look at the national data, and we've got to come up with something that's better than simply 50-minute hours. It has to be broader. And this is really an outside of the box idea, but West Virginia is gorgeous. We have a beautiful state. We have to think about how do we use the outdoors? How do we do adventure therapy? How do we get students away from screens so that they're physically more active and so that they're engaging with mentors and with teachers, with parents. And so, this is a plug for Adventure West Virginia. We've got to get Adventure West Virginia kinds of activities throughout the state of West Virginia. That's our currency. So, Dr. Hopkins?
The only thing I can think to add, I went to medical school, Eastern Virginia. Opening orientation, the professors were going around, are you from the Richmond suburbs too? I think it's something that training for years and years has been focused, giving an advantage to especially suburban and urban populations. I think over the long term, we want to look at how we can grow our own, how we can train providers that want to live in the beautiful area that West Virginia has to offer, that don't look at Morgantown as a county of 100,000, give or take, as way too small to even consider. I can't wait till I can go to Pittsburgh. I know that's something we look for in our interview process when we're trying to find a new candidate. We don't want somebody to be with us for 6 months as a new psychologist and then pack up and go to Pittsburgh. If we want them to give them a realistic picture so that they're willing to stay here. I think we grow our own. I think as many providers as we can have, we can fill their slots. And I think the students are really craving that. I wish I had a better answer than a longer term, but I think there are solutions.
Thank you, Delegate Tully. And then we'll have Senator Rucker will have the last question because we're running out of time.
Thank you, Mr. Chairman. Thank you all for being here. What relationships do you have with your local emergency rooms as far as WVU, Mon General, and any of the other emergency services providers to do automatic referrals? Say somebody doesn't meet inpatient criteria, but they are getting discharged from the emergency room. They're there for maybe depression, some type of mental health issue, or a suicide attempt. What type of relationships do you have? Is there an established discharge process where you can get a consult?
There is. In fact, part of my job role is also to do calls through Chestnut Ridge and Ruby's emergency department. The college student I saw this morning is going to be seeing me later this week. We do have protocols in place so that Healthy Minds University is a very common referral point. We've educated our team of psychiatry residents who cover the emergency department 24/7, 365, how to make those referrals, how to get these students connected with care. Sometimes it still is a little bit of an access issue if there are no open slots or we're full on providers. But I think it's a little bit more challenging with other healthcare systems that don't share our medical record because there has to be some sort of communication. There have been examples of barriers with that in the past with MON, though I think that there is the spirit that everybody wants to improve that communication. So that's what we do.
And what about the comprehensive behavioral health centers? I'm assuming that you guys have one here in the Mon County area, and how much work do you do with those?
We do. So I'll speak to that in a second, but we are working with Mon General to create the same sort of relationship that we have with behavioral medicine. But for those of you who aren't in Morgantown, what's really concerning is the emergency rooms in our more rural areas. And so one of the things that I hope that a task force will look at is how do we create MOUs with the emergency rooms in each of our rural counties so that we can ensure that there's some sort of collaborative relationship. And we absolutely have to partner with the community mental health centers because we don't have the resources to provide students with longer term longitudinal care. And that really is the responsibility of community mental health settings. And we've begun to do that. We're actually working with Valley Healthcare Systems to develop a crisis mobilization team that will serve our students and the broader community. It takes a village to do this. We can't do it at the higher ed level. It's going to take all of us to begin to fix this.
And I'll have one more part of that. The other thing, how much outreach is done with any of the providers in the rural areas? So, for example, I work for an FQHC in one of the more rural areas. And I know that I didn't know a lot about your services really up until today. And actually, I finished a graduate degree in 2018 from WVU. So how much outreach is done to let those providers know that these services are available for students that you may see for primary care, but then come away to college? So that would be probably very helpful, I would think.
Oh, I think you just answered our question, not enough. you know, the bottom line is we keep our heads above water, and that's a really good example of something that we all need to do more of, because I think that those referral sources are critical. Absolutely.
Thank you.
I do think if you go to W Medicine's Behavioral Medicine's website now, Healthy Minds University is one of the more touted clinics. It seems like everybody from the top has been committed to increasing our visibility. Dr. Marsh has been interviewing our applicants for positions at Healthy Minds University. It is something that the health system has been fully supportive of and is trying to make us as visible as possible. I also know over the years, just those relationships, residents that graduate from W Medicine and go to other communities. There's one in Beckley, for instance, that I coordinate with, and since he was a resident here a few years ago. So it's oftentimes about fostering those relationships.
Thank you.
Thank you. Due to time, we're going to probably have to cut this short. We have 2 quick items on other business. I know I have a bunch of questions, so we'll probably submit some to you all, and we may end up getting you back some time, but I appreciate each of the speakers today for presenting. Senator Rucker, you have an item on the other business?
Yes. So last month, the Joint Education heard from LSIC, and our council has drafted draft legislation to address some of the things that were brought up. So I'm going to ask him to please pass it out. Please take your time looking at it, review it, and then give us any feedback you have. It's just a draft, and it's certainly not trying to be comprehensive, but I want to make sure all the committee members have input. And my hope is that as a committee, we will adopt legislation that we want to do at the next legislative session to address those issues.
And as a draft, there's no leaks, guys. Got it. Second item on other business. John True, President of the Board of the West Virginia Academy Public Charter, is offered to give tours of their facility tomorrow morning at 7:45. So any members that would be interested in seeing their progress, we don't have transportation there other than by ourselves. So probably somewhere around 7:30 tomorrow. Anyone who wants to go, we'll try to get a number of us to bring them over. Okay. Any other items of business? All right, I'd like to thank, Hannah.
Just very quickly, Mr. Chairman, just to brief the committee, I'll try to be mindful of Lucia's time here at 4. I think we would kick ourselves if we didn't talk a little bit about what happened, or at least start the discussion of Fairmont State and what happened last week. I had the student body email me to share with you guys today their response to the issue that happened last week. So I'll just read that real quickly and I'll turn it back over. It's the official statement of the Fairmont State Student Government Association, the voice of the students at Fairmont State, as well as the vast majority of staff and the community, that Dr. Martin be reinstated as president of the university with all powers outlined in her previous contract effective immediately. Furthermore, I ask that Dr. Diana Phillips be barred from any position, be it acting or interim, where she may hold powers previously delegated to the president, as she has never once shown any type of support for the students at this university. Dr. Martin was handed the attached letter the very second the motion was made. It is clear to the unbiased eye that Dr. Martin was wrongly terminated and that this decision was made prior to the issuance of said notice. This is not only morally wrong, but the legality of such is in question. As a student of Fairmont State University, we plead for the aforementioned, not because we feel a sense of loyalty to Dr. Martin, a woman who did in fact save this institution from utter failure, but because we feel a sense of loyalty to the university we attend. The Board of Governors has not only failed us, but failed the greater state of West Virginia. Sincerely, Zach Taylor, Fairmont State University Student Government Association President. And I know we've had the discussions before, but I think it'd be very beneficial to this committee as well as Lucia if we maybe had some of the Board of Governors come before us in the June interims.
Thank you, Delegate Hannah. To follow up on that, I did ask David Goldberg, who's the chair of the Board of Governors at Fairmont, to come to Lucia today. He had a prior commitment, but I did want to get an initial brief statement. It is something we will bring up at the June meeting, so we'll go in more detail. But since this just arisen over this week, wanted to have something brought up. We can do that in the same with the Education Committee if we want, but we felt it was the Oversight Committee would be more appropriate. So I just wanted to let you know that that was being addressed. Okay, and there has been public report in Metro News people have seen, so you can look at that for basic information, but we'll get more details later. Any further business before the committee? So we don't run over too much time. Co-chair is recognized.
I motion we adjourn.
All those in favor?
Aye.
Aye. Those opposed can stick around.